shipped to Rwanda, and this is done through the collaboration and partnership between Rwanda with BioNTech to make sure that we have the infrastructure to locally produce vaccines. At the same time, there's also need to make sure that also there's a strong regulation for medicine, and for that there is a Rwanda Food and Drug Administration that has been strengthened to really ensure that they're ready to assess, but also to make sure that the vaccine, any other product, is of quality before going to the market. At the same time, also there is a need also to really make sure there is the workforce to really operate those vaccine manufacturing industries. And there's also currently a discussion to really make sure that we also have the capacity building for our workforce to be able to operate in those industries. So, kuri health fund impact ni igitekerezo dushigikira ng'u Rwanda. Igitekerezo ni kimwe n'izindi bitekerezo yo kongeraho ubushobozi kugira ngo dufashe amasosiyete cyangwa se amakampani cyangwa se no gushyiramo infrastructures kugira ngo izo initiative yo gukora ingingo cyangwa se imiti mu Rwanda zibashe kugerwaho. So iyi tuvuze kuri initiative ni ukuvuga ko African Health and Economic Transformation Initiatives ni initiatives yatangiye n'abajesuite Kenya bakoranye n'abandi bakorana n'izindi universite kugira ngo babashe kumobiliza amafaranga izafasha abanyafrika kugira ngo bashyire mu bikorwa izo nganda zo gukora ingingo cyangwa se izindi miti muri Afurika. So iyi conference ni conference duteganya ko iyi initiative izaba itangiye mu mugaragaro. Muri nama hazabaho kuganira uburyo iyi initiative izashyirwa mu bikorwa, kandi Rwanda tumva ko tuzakorana kugira ngo natwe tubashe ku benefitinga kuri iyo initiative.
Murakoze cyane.
Health Fund? Yeah. Ubuntu. Yeah, so we are establishing the Ubuntu Health Impact Fund. First of all, it's a fund, which means
just want to start.
okay.
Yes, it's possible.
Okay. I should be looking at you.
It's okay.
I should be looking at you.
If you want, it's all right.
Okay. Yeah. So we are establishing the Ubuntu Health Impact Fund, which is a way of incentivizing pharmaceutical innovation and production in and for Africa. As you know, to innovate, to produce pharmaceuticals and diagnostics, you need funding. But in the current scheme of things, okay, which is guided by the TRIPS model, there's more innovation and more pharmaceutical production in the north, in the developed north or the west. And because that's why there's a promise of profit when innovation is done. But what this fund will do is that it will promise to reward those innovators and those pharmaceutical producers who are producing for Africa or are repurposing their medicines to have an impact on African disease and bring down the disease burden. That's why we have the word impact. Yeah? And there's the other word, Ubuntu, Health Impact Fund, because this fund is driven by humanity, by those innovators and researchers and experts who are concerned about what is going on in Africa. But while we appreciate that Ubuntu is enough and is good to promote what we want to do, we also appreciate that these people driven by humanity, by kindness, by concern, are also rewarded. So this fund will reward those who are practicing Ubuntu. Yeah. So we sort of give it to support them to ramp up production. As we know, one of the key blocks in the process of innovation, pharmaceutical innovation and production, is financing, and that's why we are providing this fund, which we hope to reach maybe 5 billion over the next 5 years. But for the next 1-2 years, we have built a fund to the tune of 100 million to support Africans or non-Africans who are producing in Africa and for Africa. As we know, there's very limited production of pharmaceuticals in Africa, to only 1%. And through efforts like the fund, we want to increase that, as the minister said, to at least 10%, and then keep growing.
How many countries are you in so far?
Well, we are in the Haiti, we're a network of several people, so we are all over Africa. But in terms of the effort, we want to start regionally. Like, we want to do some efforts in West Africa, maybe through Ghana, where we've started, and Central Africa, where we are here in Rwanda and Congo, and East Africa in Kenya, as well as go to Southern Africa. But we want to do this, or we have a plan anyway, to do this very, very fast, because the problem is urgent and it needs urgent solutions.
Thank you.
You've been interacting with local officials, and are they supporting you?
Yeah, we, for example, here in Rwanda, we are in very good collaboration with the government in general, and especially through the Rwanda Biomedical Center, the RBC, as well as the Ministry of Health itself. Well, that's why you saw the minister is here. And this, what we're doing and working on together, will not end in this conference. We have a plan for greater collaboration, you know, because we really believe that what we are Pan-African, and we really believe that what Rwanda is doing is an effort not only for Rwandans, but for the rest of Africa. So we are in very good collaboration space.
Speaking of Pan-Africanism, you're dealing with different countries
Yes.
that have different regulations,
Yeah.
different institutions. How do you plan to harmonize all that and to bring them all on board to participate?
Yeah. One of the efforts of Haiti is advocacy. And we are also not only working with individual governments like Rwanda, we are also working at the level of AU organizations like the CDC and the AU NEPAD, who are focused on this topic. And one of the issues that you have really brought out, which is our concern, the disparate regulation mechanism all over Africa. And if we go that way, we will not be able to defeat disease. So we are working with them and several others to push for harmonization of regulation, so that, for example, when something is approved in Rwanda, which is a member of the AU, that should be approved for the rest of Africa, just as it is in the AU. So we are not only focusing on production of medicines, but also ensure that there is the requisite and right policy context, including regulatory mechanisms that are harmonized. Yeah, so that what we're thinking about are the 1.3 billion people in Africa. You're not thinking about Rwanda alone. You know, we cannot defeat the problems we're facing at the level of a country alone. We need collaboration, as we heard from the minister.
Then,
and trust me, we're really working hard to work with others so that regulation structures are harmonized.
Then Aheti will be one among many advocacy institutions in that area.
In that
Do you
regard.
have specific tools that will ensures you that your advocacy will, one, reach further, or at least be effective in some countries?
Yeah. The biggest tool I can say is our strategy. As you saw, we are collaborating with governments, engaging them at bilateral level, but we're also working at multilateral level with the AU, plus other international organizations that we are working with. So we have some very good relationships, and so we will not push alone. We will work. We are already working together with others, and this involves those in policy, those in academia, those in the civil society, so that we work together for greater impact.
Have you faced any pushbacks so far?
Yeah, but they are minimal, because it's just the slowness sometimes of the movement, which, like as you rightly put it, we need to have strategy to really ensure that things go fast, because diseases don't wait. As you and I speak, people are dying, so we can't wait anymore and any longer. And as you know, we are also representing a very widespread network of faith-based or Catholic organizations, and that way we are able to reach various countries and ensure that we engage at that level as well. Yeah.
How do you raise this kind of funding?
This funding is a cocktail. It's a mix of various funds. Yeah, there's what we call impact investors. That means there are those investors that are interested in doing good, to have impact, and they would like to deploy their resources, their financial resources, in an effort like this. And so we have a promise in there through impact investment. The other bit will come from donations. We've already engaged donations from philanthropists, and both at individual and organizational level, as well as we're mobilizing support from developed or rich nations. So it's a mix, and we've designed it that way. Yeah. Thank you very much.
Efforts going on in Africa to try, to
So we can start
Few
seconds.
there's a lot of efforts now underway in Africa to try to empower the pharmaceutical production industry. What is the US doing to help in this regard?
So I think we talked a little bit about the World Trade Organization and the intellectual property rules at the World Trade Organization. Father Charlie had referenced that we worked with African governments and other World Trade Organization members to have a waiver of some of those rules at the request of the African delegations in order to be able to facilitate production of COVID vaccines in Africa.
Are there any challenges if you have looked at what Africa is now doing now? Are there some challenges that you can single out that we need to address so that we get moving fast?
I think part of this initiative that is being launched today recognizes that there are a number of different challenges. I think they talked about some of the policy challenges, financing challenges, logistics. I think we need a range of solutions to be able to address the problem. And what we did at the World Trade Organization is part of that broader conversation.
today is the birthday of Haiti here in Kigali. The most important thing is that Haiti is not just a conference we are organizing for people to present papers and ideas. Haiti is being launched with 7 products. Like one of them is Ubuntu Fund, which will be a fund that is targeting $6 billion US fund to improve the robust manufacturing of pharmaceuticals in Africa. But before that, the second child must be born after Ubuntu Fund, which is the biomedical research facilities, where we shall collect genomic data, because in that facility, we've been told that Africa has the highest gene variation. And with the highest gene variation, if we collect that data and add to the global pool, because the global pool of data for genes in the world, Africa contributes only 1%. While that means that the medicines or therapies being developed in the world don't target Africa. So by collecting that data, we're able to do precision medicine, because now we shall be doing medicine that links to the genes that are in Africa. So that's the second child. The third child, we shall have a data repository where after this genomic data has been collected, we shall get data in all health informatics, like number of beds, number of facilities, diagnostics machines, everything that's about health, we shall collect and have this data repository for the rest of Africa, so that you can have a one-stop shop for all data that you need in health. And the fourth child is now a pharmaceutical tech lab, now where we shall do molecular trials, clinical trials, after you collect the data, so that you can actually end up now doing the candidates for medicine as therapies for helping Africa recover from the diseases. And of course, the fifth child after that will be how can we be able to train the human resource for health so that they can be able to manage all these things we are talking about. The seventh child is primary health care, because before somebody swallows a medicine in their mouth, your work is not complete. You can manufacture, you can do research, but the last mile, the key performance indicator, is how many Africans can access essential drugs in their homes when they can take them and swallow them. And the last one, which is the seventh child, is how can Africa showcase what they have done? And that's what we call Africa Health Expo. There will be annual Africa Health Expo, the first one beginning on 14th of June this year to 17th of June. So that's what we are passionate about, because we have discovered that because market failure is real, there's a shrinking role of the states. States have not been able to offer this essential commodity, which is health. Now we have to have Ubuntu spirit, because the world is driven by passion, by love, much more than economics. I know people like money, but it starts by what you feel in your heart. What do you want to feel for the other? That's we call it Ubuntu. And we welcome you to this Africa for All movement. It is not just for us as a Haiti, but we want the whole Africa to join us so that we can walk this journey together. Thank you.
Yes, Honorable. What is your last words, your input, and takeaway? We have been so very interactive, as a motivator to the research and science. So what is your last word as an African? Do you think as an African, as you are resilient, as you take, you put a seed? What is your last word you can address all over the world?
My last word as the CEO of Haiti, we have what is called can-do mentality. There are so many things Africans have been told they can't do. And I can tell you we can do it. In fact, Africa has leapfrogged the world with mobile technology, where we have mobile money. Because of technology and genomic data we are going to collect, Africa will leapfrog the world in pharmaceutical production. I believe in it. We are believers. Because we can see it, we'll make it happen. Thank you. Sure. Thank you.
The first estate is the public sector. They are the first where the minister was, that is the first estate. The second estate is the private sector, who are sitting here mostly. The third estate is the civil society. And the civil society NGOs form the third estate. The fourth estate is the media, to report the three estates. So we have just finished with the fourth estate. Of course, the interviews about what was taken today, because we don't want anything to be lost. Now we want to move into the panel discussions. And the first panel is going to come forward. I'm looking at John Paul. Are you the one coming? So I would like to take this chance to invite the first panel. Their presentation has already been uploaded, and this panel will be run by John Paul Omoto. I don't know what his title is, but let me talk about what I know that he has done. John Paul Omoto he works for PATH. John Paul Omoto has been very instrumental in working with the African Union, or if you like, the ADUEA, NEPAD, in developing what is called pharmaceutical manufacturing plan for Africa. And of course I'll challenge him, because he told me that has been done for over 7 years, isn't it? So in Africa we can spend 7 years to plan, isn't it? But we have not yet manufactured. So you will have to ask them the questions that you can ask. But I want to give him the microphone so that he can call his panel to come forward and then guide us in that panel with that very little challenge. I don't think you mind too much when I make this joke over you, Paul.
Thank you so much. When my seniors speak, I listen. And I oblige. I hope I'm fine with here. It's still morning. Good morning. Good morning. Yes, see Michelle there. Hi. We are having a very exciting first session, which is in your program, it's written the plenary session. And we're going to speak about access to safe, effective, affordable, and quality medicines in Africa. The challenges and the recommendations. I think as we are looking at this topic, we really need to start thinking through what does access mean. Health experts in this room understand that health access would have many faces. And when we're talking about the challenges and the recommendations in the access, the effectiveness, what does effectiveness mean? And how then do you measure effectiveness within the health sector as we're thinking about medicines, as we're thinking about the service delivery? What does effectiveness mean? Affordability. When do we do trade-offs for affordability, especially when you're looking at the cost? And is cost the only way of looking at affordability? The other one is around the quality. And when we were doing, you remember, it was mentioned that we did the benefits package, the essential benefits, UHC essential benefits package. My professor Kokwaro told me, how then do you measure quality? And he used the acronym STEEP, which I would expect our panelists to speak about. And therefore, I think the people will help us unpack this further through real-life situations, real-life experiences, real-life work. A great team of panelists, and I would ask them to come in front. And please, as I call each one of them, I would just ask you to join me through the following. Just do like this, clapping. Let's try that. For each one of them. So the first person that I would like to speak to, or rather to come, is Eugenia Mpofu, who is the PhD Associate Professor of Economics, Kwame Nkrumah University of Science and Technology. Let's go. The second would be Father Francois Kabore, who is the PhD and Professor of Economics, Kosam Jesuit University of Science, Burkina Faso. Let's do it again. And then we do have one of our very own from Kenya, Dr. Robert Karanja, the co-founder and chief innovation officer of Vilgro Africa. Robert Karanja, he always has a hat. Thank you so much, Robert. Welcome. And I'm not sure whether we have Noela. Noela would not be here from the RBC, and I would not want to ambush Dr. Cloud. But I think Dr. Noela Bikirima was meant to join us. I'll be advised on whether she'll be able to join. Otherwise, Dr. Noela is the Deputy Director of the Rwanda Biomedical Center. And I think at some particular point we might give any of the colleagues just to say a word or so, because we might not have our talking points. So thank you so much, colleagues, in this. And I know you already have your presentations ready. I would ask that I start with Sister Eugenia with your presentation to really speak to us about access to safety, effectiveness and affordability and the quality of medicines in Africa, looking at those challenges and recommendations and those concrete things that we can get from this point, from this conference. I think we were told we are no longer theoretical, we are going to be action-oriented. Welcome, sister. Yeah, I think we can go this end so that it makes it easy. Yeah.
This is too tall for some people. You don't want it down here.
Oh, okay. Okay. I think, can we... Sister Eugenia. They're just setting it up. It's not working. Eugenia. I'm off stage. Yeah. How did you know? No. Maybe if you... How did you write? Apologies for the small delay. And maybe I'll ask some colleagues to help me move this down here. So that...
It's that late.
I think when now you can, I don't know whether put this. Yes. Put it on the side somewhere.
Or she can stand here. She can even stand with that.
Yeah, so you maybe stand. Yeah, so that you are here, it doesn't block you. You don't even need to, but you can just. Yeah.
Oh.
Yes.
Good morning.
Good morning.
And I'm happy to be here. Thank you all, the organizers, for inviting me. And as you can see, talking about access to safe, effective, affordable, and quality medicines in Africa. I'm going to focus on factors or challenges that affect these factors. And my name is Eugenia Ampofu. How do I change? My name is Eugenia Ampofu, and I teach at the Economics Department of Kwame University of Science and Technology. I'm also a sister. I belong to the Daughters of the Most Holy Trinity. We are in Ghana, or we're also known as the FST Sisters. Okay, so just For a start, I'll give an outline of the presentation. First, there will be an introduction, and we'll look at the specific challenges in the area of assessing safe, effective, and quality medicines, and then I'll give some recommendations. So to start with an introduction, I think we've heard a lot about the situation of the health situation in Africa, that we suffer from so many other diseases, like high mortality, high morbidity when it comes to malaria, tuberculosis, and HIV. And in 2015 alone, about 1.6 people died from these diseases. And if you look at the whole world, malaria cases, about 90% of them occur in Africa. HIV is still taking a lot of lives in Africa. More than 70% of deaths that occurred in 2011 were from Africa. And in children, a lot of children are also dying from pneumonia. It used to be malaria, but because malaria has received a lot of attention, it's become less dangerous, but pneumonia is taking over. So we are still being attacked from left and right by all these diseases. And so the question is, what is causing these problems? What is causing this adversity? And one of the main problems is lack of access to safe, effective, affordable, and quality medicines. And so let's look at the factors or the challenges that is causing this. Let's start with, can I come down? Thank you. Okay. So as you saw from the outline, the high cost of raw materials is one of the challenges that we are facing. And when we talk about raw materials for medicines, we have the active pharmaceutical ingredients and we have the inactive pharmaceutical ingredients. And when you look at these active pharmaceutical ingredients alone, there are various sources. And they move from plants to synthetic ones. So we have plants, animal, microorganism, marine, mineral, synthetic, semi-synthetic, biosynthetic. They are all there. They are all very important sources that are needed. And these are playing a very important role when it comes to the cost. And how do they contribute to the cost? If you look at Africa, most of the drugs that we produce, the ingredients that are needed to produce those drugs are imported. About 95% of the active ingredients are imported. And it's not only the active or the raw materials that are imported, the equipment that are used for the production are also mostly imported. And why is that a problem? Okay, now, if the raw materials are imported, it means that it's going to increase the time or the lead time, the amount of time that is needed to produce the product. You have to wait for the inputs to be transported from outside before they reach where you are, and that increases the time, and you know that time is cost. It adds to the cost of production. In addition, usually suppliers give what you call credit terms. Like if you're able to pay them within a short time or within a stipulated time, you get some discount. When you have to wait for a long time to get your inputs in, it means that that credit terms is going to be eaten into, and you end up paying more for your input and adding to your cost. And of course, in many countries, a lot of these inputs are subject to taxes, and they don't get refunds for that. And there's also this argument that the producers, the outside producers of these inputs can also be competitors because they're also medicine producers. And so they may have the incentive to delay or to add to the cost of these inputs, so that by the time it gets to you, become less competitive. And they will send their own final product back to Africa for us to sell. And of course, if you are going to import a lot of your inputs, your business is subject to exchange rate risk, and we don't know what it means. Okay, in addition to this, the fact that we import everything, you also need to look at the type of input that are used for production. Well, currently, given technology, the technology that we have now, if you use more of these synthetic inputs, it's it's much cheaper and the quality is better. But then you have to have the technology. The type of technology that is needed is currently not available in our part of the world. So we are subject to this problem. And consequently, the cost of production remains high. And when the cost of production remains high, the output becomes more expensive and less affordable to the poor. Not only this, not only do we import a lot of the inputs, we also import a lot of medicines into Africa from outside. And as you've already heard, if you look at the global production of pharmaceutical manufacturing, 3%, only 3% of these products are produced within Africa. And the sub-Saharan Africa alone, between 70 and 90% of medicine that we consume are imported from all over the world. Okay, and we know the consequences of this, and we felt this a lot during the pandemic when there was supply chain interruption, and when there was shortage of essential medicine, and people lost their lives as a result of this. We know, according to research, locally manufactured goods are more able to penetrate into the remote areas than the imported ones. It's more likely to find a lot of imported or donated medicines, expired in the shelves of regional medical stores than to find that for the locally manufactured drugs. And as a result of this, many drugs are not available. Sometimes not necessarily because they are not there in the country, but they have not yet been distributed. There are countries that have very good distribution mechanisms, like Ghana has adopted the drone. Then that takes a lot of time. But with the drones, they're able to send a lot of these medicines to the remote areas. But you have to be prepared to pay for the cost. Not only do we depend on countries for medicines, we also have a very poor supply chain system. Okay, and that is a big problem. When we're talking about supply chain, we're looking at the network, the network of all those involved, individuals, resources, companies that are involved for the production of a given output. Okay, so when they are not well managed, you can be sure that things may not go as we expect. And when you talk about poor supply chain system, we are not only looking at the supply chain within Africa, but it may also be outside as well. If you are importing a lot of your products, it's difficult to keep track. Even if you have a very good monitoring system, it's very difficult to keep track of the supply chain that starts from another country to make sure that you monitor to ensure quality is assured. It's very expensive and it's very difficult. So in general, we say that counterfeit drugs that are produced globally, 42% of these are produced within Africa. And some studies have shown, they looked at a lot of medicines produced in Ghana, they concluded that 39% of them were substandard. And when they did the similar study in Nigeria, they found that it was 64%. And I'm using these countries because that's where I come from. I didn't want to touch any other country because I know that these are not the only two countries that have these problems. Okay, so as a result of this, what do we have? We have shortage of essential, safe, effective, quality medicines. And when you go to our retail pharmacy shops, there is shortage. If you go to the OECD countries, you get above 90% of such drugs available. But when you come to our part of the world, about less than 40% of them will be available in public stores. Okay, and this is where the bulk of the population is supposed to access healthcare. They go there and the medicine is not available. The same thing even with the private sector, it's less than 60%, but when you go there, it's more expensive. So even though the drug may be available on the market, you may not be able to buy it. So it's not accessible to you. So we have high mortality rates simply because of this, not just we don't have the drugs, because we can't afford it. Okay, so we have the government coming in. Now, after talking about all this, the question will be like, what is the government doing? What is the government doing? If you look at African pharmaceutical manufacturing, most of them are small and privately owned. they are not governmental. Of course, we have some publicly owned pharmaceuticals, like in Tunisia, Mozambique, and South Africa, and Algeria as well. We have some pharmaceuticals there that are owned, or which government have a lot of shares in their operation. But in general, as a result of this low investment from governments in the pharmaceutical world, we have inadequate infrastructure for the distribution of medicine. I mentioned Ghana, that is trying to use the drone to ensure that medicine is distributed to the remotest areas in Ghana. But this is just one of the few countries that are doing that. In many countries, people in the remote areas die simply because there's no medicine available to them. Okay. And then when they're looking at the expenditure on medicines, you're looking at the components. Very often, 60% in Africa and India, 60% of them is borne by the individual. Because the government only bears about 40%. So it's more market than public. Even though we are talking about health being a right, and then becoming health being availability of the affordability, your ability to have access to it. So there's weak government regulations. And because the government is not up to task when it comes to monitoring to ensure that things are done properly, quality of the drugs that are in the shops are questionable. And as a result, we have problems with affordability, the high cost, with quality, safety, and then the effectiveness of our medicines. So, what do we do? Just because they said I had only 10 minutes, I had to limit it to 1 page for recommendations by fact. So obviously from what we have looked at so far, what I've mentioned so far, we need to look at local production of essential medicines. We want them here. If we are able to produce medicines right here in Ghana, it will reduce the lead time. And when it reduces the lead time, it means that credit that is given to produced by suppliers can be taken advantage of, and the cost of raw materials could go down. It will not take too long for manufacturers to manufacture a given drug. So what can we do to be able to achieve this? Okay, we know that pharmaceuticals or producing medicines is very complicated. It's very involving and it's highly capital intensive given our current technology. So we may not be able to do it alone. Africa may not be able to do it alone. There is only an African company or Africans only or all that. But we will have to do what we call collaboration. Public-private partnership. The government cannot stay out. The government has to be part of it. The private sector can come in. And the NGO as well. By NGOs, I'm looking at the faith-based organizations, like the churches, the Catholic Church, and the other churches as well. To come in. And this can take the form of technology transfers. I think something like this is occurring now with the help of WHO for some of the countries in Africa for the production of vaccines here in Africa. We can look at technology transfers brought here as a starting point, so that the originators can allow companies here in Africa to use or to adapt the given technology, or maybe modify it a little bit to suit what is good for Africa or to suit our needs, so they'll be able to produce the type of medicines that will be able to treat the diseases that affect us. The production of input. So when we're talking about local production, we're not just looking at the final products, we're looking at the very beginning as well. So we're looking at the production of raw materials, both the active and the inactive ones, ingredients, equipment for production can also be considered right here. So that in the process, it will reduce the lead time for production and reduce the cost of production, and consequently make medicines more and more affordable to our people. Of course, you can also start somewhere with filling, finishing, and packaging. So put all of these together and get the whole supply chain put together for our consumption. Now, to be able to do this, I remember I said that it's capital intensive, so we need innovative financing to be able to attract foreign investment. One thing that typically we are not good at is that when we sign partnership contracts, Africa has been signing a lot of contracts. When we sign these contracts, they don't really end up favoring us as much as they should. So when we are signing contracts for such purposes, we want to make sure that there is job creation within Africa. That kind of contract that we are entering in is able to promote economic growth. There is enough local content so that not only do we consume the end product, we are able to get a job that will help us to afford those products that are being produced, so that we improve the health of the individuals or of the people. And because of our poor supply chain system, we have substandard quality or substandard medicines. If you are able to improve monitoring to ensure that the products that come out of our factories are of high quality, people will be able to have access to quality healthcare, irrespective of where they live within Africa. We need Haiti, for example, to be able to lead this kind of operation or project, so that there will be some trust. There should be some trust in locally manufactured goods, that they have been approved by Haiti. If they are approved by Haiti, people may start to think that, oh, made in Africa can also be of high quality. You need something like that, a new thing. Of course, as I said, there is absolutely no way you can do this without the government. The government also has to come in to ensure that there is direct or indirect foreign investment. You can't do that without the government. The government has to come in to ensure that the regulations are well followed and well kept. The government has to ensure that the regulations are even, there are policies, and there are these policies that are effective as well. The government has to come in to ensure the collaboration works. The commitment of the government cannot be overstated. So with this, I believe that we'll be able to ensure that people will have access to safe, quality, effective, and affordable medicines. Thank you very much.
Thank you so much. Thank you so much. Round of applause. I think we had a pattern to take. Let's take the pattern. 1, 2, 3. We forgot it. Let's do it again. 1, 2, 3. Thank you so much, Sister Eugenia. I think you really provided us and articulated some of the things that really are aiding the access, affordability, and quality. You've talked quite a lot about why we are where we are, the issues of importation, the issues of our dependence, the issues of poor supply chain, government involvement, and provided very clear recommendations, right from increasing local productions, collaborations and coordinations, innovative financing. You had of strengthening the regulatory landscape and government involvement and leadership in that. Thank you so much. I think because of time, I would quickly request Father Francois Kabore to come in. We will have 10 minutes. I'll ask that you try and keep time because we started a little bit late with this session. And I would like to keep to the script that was there before, where we start in time and finish in time. So thank you and welcome. Let's welcome Father Francois. 1, 2, 3. Francois. Oh, I'm pronouncing this. Pardon me.
Thank you very much, everyone, and thank you, Father Charles, for having me here. It's a real pleasure and an honor to be here. So, I'm Father Francois Pasitouin de Kabowe. I'm originally from Burkina Faso in West Africa. And also working at Coastal Church University of Science and coordinating the Association of Church Universities in Africa and Madagascar. For this particular work, I collaborated with a friend, Frank Zongo, who is a pharmacist working at the WHO in Chad in Central Africa. So, as we speak about the impact of human capital in the access to health in Africa, I want us to picture what I'm talking about when I think about Africa, because sometimes we don't realize that we live in a continent where I just came from India 2 days ago, and this is where India will feed China, US, and so on, and there is still a lot of space left. This is the continent we are talking about, please. And in terms of data, the land mass, it's 20% of the world land mass, 54 countries, 1.4 billion people, 75%, as you know, of our youth, of our population is youth, as defined by the UN, 0 to 35 years old. But the number of doctors per capita is 18 for 100,000. This is what we are in Africa, compared to 1 doctor for 800 people in India, or 1 doctor for 500 people in China. And the number of nurses, we have 1.1 for 1,000 people in Africa. And in terms of resources, I did not have enough space to put it, because as you know, if you need any resource on this earth, you go to Africa and you find it. So, the question I want to raise here is, what explains the poor health delivery in Africa and how to solve it? As Freddie would say, we want to be action-driven. Specifically, the questions I would like to ask specifically are indigenous capabilities part of the story? And second, is international knowledge production environments, such as IPR, intellectual property, and the dynamics of innovation in the world, can that also explain the poor health delivery? So when I ask these questions, try to answer them, we'll follow some recommendations. So, as you can see, the hypothesis I'm putting here is that human capital and intellectual property rights are the major determinants of the poor quality access to health in Africa. And this is what I'm trying to show you, please. So to do so, I will clarify 2 things. First, NTDs, neglected tropical diseases, then the access to health, how I understand it. These are working definitions, and based on that, I will highlight 2 challenges. The first one is patenting and IPR, intellectual property rights, and traditional medicine. And second, my recommendations, I will have 3 of them: the issue of common properties, second, creativity and employment, and third, what I call the quadruple helix of knowledge economy. My area of expertise is knowledge economics, so I can speak only from what I know, please. So, neglected diseases. What is it? I'm not a medical doctor, but we have many of you here, and as you know, these are a lot of diseases, 20 of them at least, such as malaria, liver blindness, and so on, which affect mostly impoverished communities in tropical areas. That is basically in Africa, please. The problem is, I often hear people say, well, malaria doesn't kill. As an economist, my point is not just for you to die. If you die, this is too bad, it's a loss. But the problem is, we need to look at the economic consequences of it. Not only we have devastating health, social and economic consequences to more than 1 billion people according to the WHO, but more importantly, based on research done in Burkina Faso, those who are affected by malaria and liver blindness have their productivity reduced by 1/3. So even if you don't die, you are economically impotent. That's the issue. And that's something that's very, very crucial. More importantly, as we speak about human capital, which is a combination of education and health. And I'm going to come back to that later. All studies show that with good human capital and health, it increases your lifetime revenue by 3 to 14%, which means that when you are sick, even if you don't die, you're going to lose 3 to 14% of your revenue. So just don't count the dead people, count also those who cannot actually contribute properly to their economic life. So you can forget this, but just to mention that when we talk about economic production, wealth, and so on, we talk about technology A, K is physical capital, L is labor, and H is human capital, like expertise. And you can see that this is like, most of the time we focus on K, which is 1/4 of all these things. And as a matter of fact, in terms of weights, K doesn't even weigh as much as human capital. So when we talk about access to medicine, we can focus on availability. And I think yesterday in our small talk, Freddie mentioned that availability is one of the steps towards accessibility. You need to make it affordable. Sister Ejina mentioned it. You need to make it reachable. If I can afford a medicine here in KIGALI, but the medicine is located up there in Tanzania, whatever is going to help me at all. But more importantly, the other piece that people don't often mention is the capability and the ability to even use it. If you are sick and you cannot swallow anything, and the medicine is in front of you, you are a dead person. This is accessibility, please. Based on that, what are our challenges? The first one is that we need to realize that we have a shortage of appropriate human capital. In our countries, as we know, all our universities are training unemployed people. It's shocking to say that, but that is the truth. We have a shortage of 2.3 million doctors, and that will increase to 4.3 million doctors by 2035. So, and we have done a study on 35 countries more or less, 32 African countries. It's a public data from 2013 to 2019, also checked with our own experience. And we find a negative correlation between the investment in human capital and also the expenses on non-tropical inherited disease, which is shocking because normally human capital should have helped reduce the issue of inherited tropical diseases. But why is that the case? My hypothesis here is that there is a crowding out effect between human capital and inherited tropical diseases. What this means is that when our countries try to invest in education, for example, they don't have money anymore to go and pay for drugs and so on. Which means that actually it could even be the case that when we invest in education, it's not the type of education that can improve our health system. And the second challenge is brain drain. We have published some research on that with Cambridge University, but also I did some surveys on the ground. When you look at tertiary education level of African immigrants versus those who are in the continent, among the immigrants in the West, close to 30% of them have tertiary education when you take the diaspora. But on the continent, we have only around 5% who have tertiary education. So our brains are outside Africa. And when you look at country concentrations, those who are in Canada, almost 60% of them have tertiary education. In the US, close to 50%, which means that on the continent we have 5%, but the most educated are out there in Canada, US, Australia, and so on. Please. Okay. This tells you the trend of the evolution of human capital from 1960 to 2019. And I want you to see the group of countries. On the top there, you have South Korea. In the bottom, you have Burkina Faso and Cote d'Ivoire. In the middle, we have South Africa and China. From the 60s to 2019, you can see that You know, South Korea and South Africa started at the same time, but look at how they did diverge in about 50 years. And you can understand what is happening in each country nowadays. More importantly, I look also at the gap. This is a graph that you need to understand that when the graph goes down, it means that they are closing the gap with the US, which is kind of the standard in terms of technology, for example. The country that just goes from the top there to the bottom here, which is closing the gap with the US, is China. But China started at the same level of technology as Burkina Faso in the 60s. Burkina Faso is still lagging up there with a huge divergence with China, while with the US, while China is catching up. And in the middle, we have also South Korea. That starts in the middle with Ivory Coast, and look at how they are catching up, while Ivory Coast is still diverging. This is the trend of human capital. So I'm going to skip this part because this is about traditional knowledge and giving some statistics that we can discuss in the supplementary. Please go ahead for the sake of time. So patenting and IP, what should be the solutions? You know, intellectual property are the rights given to an inventor or someone who has created innovation. And to some extent, it gives the inventor exclusive rights. To that extent, we can say that it's a kind of temporary monopoly. And these can be patents, trademarks, copyrights, and trade secrets. You know, when we look, because of this patenting issue, you can see the market for pharmaceuticals that Sister Eugenia also mentioned. You know, North America also has a big share, Europe, Asia, then Africa, you cannot even read it because it's close to 1%, 0.7%. So, I have already mentioned about what is a patent, so in the discussion we'll explain this more if you like. So, the good thing about patents, however, is that after 20 years it can go in the public domain. And when it goes in the public domain, it means that everyone else who has the technology and the capability can actually use it for the benefit of its own population. A particular type of IPR, which is related to trade, was enforced in 1994, focusing on computer programs because this is a new technology that is developing. So what are my recommendations? 3 of them. 1, we need to promote common properties based on traditional knowledge. 2nd, creativity and employment. And 3rd, the cultural index, and this is where Haiti can factor in. So for traditional knowledge, as you already know, this refers to knowledge and innovation practices by indigenous people. And we tend to neglect that. But if our people were able to live for centuries and centuries, it means that they had the possibility to take care of themselves. And this also leads to jobs and innovation and creativity. As you know, nowadays you can fly to India, to Korea, to China, and when you go in these hospitals, you are free to choose whether you want to be cured in a kind of westernized way or through traditional medicine. And this is okay. Why can we do the same in Africa? Because we don't think that good quality can come from our local knowledge, and this is something that we should think about. 2nd, generics and expired patents. There are a lot of expired patents out there that we should and we could actually take advantage of, except that this is part of reverse engineering. If you are not able to have the capability to produce it, then you cannot even take advantage of it. When I was flying from India on Sunday, in the plane, I had 2 Indians coming to Burkina Faso. And the other one would stop in Burkina and then Mali. And they are selling drugs. Because they say they develop some drugs, but others they just take expired patents and they produce it. Why can we do that? Because we don't actually have the technology and the capability. Please. The last recommendation is quadruple X. What does it mean? We need governments, academics, industry, and civil society to work together. And I think that in this room, we actually have representatives from each part of this quadruple X. And I think that Haiti can really play a role and make sure that this partnership and this networking happens. Because, you know, government should put the right rules, academia should make sure that we have true and knowledge that is grounded on facts, and then industry should make it sustainable and affordable. And last but not least, civil society is important because if you just leave industries, then they are going to continue producing for those who can afford to pay. And I think that there's an ethical issue there, please. So in conclusion, I would say that if we want to really care for access to good health, we need to make sure that we turn our brain drain into brain gain. We make sure that those who stay in our continent don't suffer from brain silencing or brain atrophy. And last but not least, what I'm advocating is what I call economy, which is a type of management that promotes the prosperity and integral rising of the nations. And this has a spiritual component. We should not just look for the wellness of the body, but also the wellness of the heart and the mind, which means that we need to put a bit of ethics in it. I thank you very much for your attention.
Thank you so much, Professor Francois. I had to get it right. I hope I got it right this time around. Thank you so much. Thank you so much. I think you really nailed it. A lot of the time, I just want to really dwell on the issue of the brain drain. I know you've mentioned so many things, right, from the access, talked about the challenges of human capital. And I think in your last slide, you mentioned the issue of the atrophy, because the other day I was walking along our Ministry of Health corridors, and I asked myself how much are we making good use of the brains, the doctors, who are within those corridors that are not being utilized. That's part of the brain drain, because a lot of the time we're thinking about those who've left the continent, gone somewhere, and how much are we making good use of those who are already there, who would be making better use of their time for the good of the health and the health system. Thank you so much. I would have, gone and gone, but I really enjoyed your presentation, especially looking at our traditional knowledge. And I know there are some of the initiatives that are currently happening within the continent to try and both preserve, regulate our traditional medicine. However, that is still happening at very sparsely within small groups of people who are not speaking to each other. It was just last week when I was talking to somebody about the same, and I told them, the best thing that we can ever do about this traditional medicine is not for all of us to do small things in our small circle. How can we bring the regulator, the industry, those traditional men and women, and sit on a round table and start crafting this roadmap towards the direction we want to take? Because a lot of those molecules could be working, but we also need to understand the toxicity levels, we need to understand the effectiveness, the dosage, and that requires that end-to-end R&D for that, and of course that multi-sectoral approach to it. So the traditional medicine is really important. However, we cannot do it alone. We must call. So I'm hoping that IHT will also take that recommendation seriously, and in one of the subsets, we bring these traditional entities, the regulators, the governments, the traditional men and women, and really look at that area of work. Thank you so much. I would like now to invite Dr. Robert Karanja. Robert, you have exactly 10 minutes. We are slightly behind time. I would really like us to keep to the time. Welcome. Let us welcome Dr. Karanja. 1, 2, 3.
So, good afternoon. I'm going to be familiar territory in the sense of being the one between you and lunch. So I keep it short and sweet. But I'm also going to be very unfamiliar territory in terms of, I was actually grouped with amazing economists. we can start here. So I typically try to, that's not mistake. So I introduce myself just this time. Robert Karanja. I am a biomedical scientist by background. Worked in Kenya for about 15 years. I was really convinced I was going to get the Nobel Prize for solving the issue of malaria. Why do you die from malaria? Then I realized I had a eureka moment that it's not about the
medicine. It's really more about the poverty. And so I started thinking more like the economists, and I think we have finally been validated by being put within this esteemed group of economists. Thank you so much, Prof. And sister. And today, basically, what I do is I work with Build to Africa, we're an early-stage investor and business incubator, working with startups across Africa, working in the health and life sciences space. Besides that, I've also now become somebody who's quite active in shaping policy, so I can speak to that. Knowledge economy, how do we get this quadruple helix going? And so that's about me in short. Moving on, so we can get to that. Boss, you're making me very popular. Let's move on. Thank you. So this map of Africa is amazing because sometimes we really forget this part, and I just understate again that we are a vast continent. The key thing to note is that out of all of that, until the other day, we didn't have much of logistics or interconnectedness across our countries, 54 of them. How do we perform in terms of the health space? We are about 4% of the global market for drugs, about 3% of the global market for medical devices, diagnostics, 25% of the global disease burden. When we talk of some of these neglected diseases, it shoots up to even 90%, 50% for some diseases. And to me, I think, to sum it all up, I just say we have the poorest health statistics on this planet, period. And why do we have that? It's not so much that we don't have the people. We are 1.2 today, but by 2050, 2.3 billion. That's a massive market. But what's the purchasing power of this market? And then we understand the way the science, the business of the science works. The pharmaceutical industry is fueled by profit. And so when they don't see the returns, and especially when you talk of big pharma, pharmaceutical industry is the most profitable industry there is, bar none. Because they get big margins, because they are able to get intellectual property rights. So Prof. absolutely spot on. So they look at Africa, they ask, why should I invest in R&D to produce for these people who are also, 9 times poorer than the global average? And that's where our main problem is. So I'm totally with the economists. Let's move on. So I thought to myself, let me speak as a scientist. I'm not used to doing this, but I wanted you to understand what we talk about when we say the genetic diseases. I did a lot of my research on Kala-Azar, leishmaniasis. And if we just follow the pattern, so this is, if you were sitting in a clinic and you have a few, these 2 kids come to you on this side, that's kind of how this disease will present itself. How many of you have ever heard of Kala-Azar? Just raise your hands. Oh, thank you. Now, when you look at that picture, what's the first thing that comes to mind? Is it this strange disease? No. It will be nutrition issues. Kwashiorkor, marasmus, I don't know what. So, differential diagnosis. By the time somebody thinks, let me test these kids for Kala-Azar, this is a fatal disease. And typically, not many children get that correct. We don't get enough time to get the correct diagnosis. So how do we overcome that? Number one, traditionally the diagnosis has always been horrible. That bottom picture there, that's what we call a spinal tap. Can you imagine? Telling this child, already looking this bad, to hunch over and you want to tap their spinal cord. And then from that, put it under a slide and then see whether you're going to identify the parasite. You mess it up, it's paralysis. Where are you doing this? In a health facility that is out in the middle of nowhere, because this is affecting the marginalized communities. Are we getting it? So what's the alternative? The alternative is, can you work with rapid kits? Can you do PCR? Then the question is, where do these things come from? And I think, I thank God that at least now we've been moving away from the spinal tap to the rapid kits and the PCR. But let me tell you, all of this is important technologies. PCR, we need multiplex PCR, so that it's not this, something else. And then the other thing is also, don't forget when the clinical history will be told of the same issues of malaria, of typhoid, fever, chills, headache, joint pains. What is that? How many diseases carry that? And then now it comes finally to our topic of today, how do you treat this disease? The first treatment, even in Kenya today, is sodium hypogluconate and paramomycin. Now, paramomycin is a repurposed drug. It's an antifungal. The sodium hypogluconate is what we call antimonials. These are compounds that have been used in the medieval ages. There's no, they've never passed any national regulatory authority. We don't know how they work, but we know there's some. They are as amorphous, this is traditional medicine. It's not safe, it's toxic. So half of the neglected diseases we talk about, the patients are dying from the treatment as much as they died from the disease. And they came into the clinic looking like that. Are we together? Are we? I come from the church. The church we get an amen now. But anyway, and so the question that I ask is, what do we have in our arsenal? What tools do we have at our disposal for dealing with these poverty-related neglected diseases? And you've heard it from everybody else. That chart at the bottom is basically saying, even for drugs, we're importing too much everything. For pharmaceuticals, 99%. And that's our data for 2019, when COVID hit us in December, the following year. So you can now see the big picture of where we're in terms of the landscape for health. Let's go to the next. So I'm going to cut the chase and say, you heard what everybody else is saying. I looked at it and asked myself, what can we do? And there's two kinds of pharmaceuticals we need to be aware of. We have the big compound, which is what is on the left hand. These are health technologies derived from chemistry. And then you have biologicals in the right hand. Now, there's some specific advantages of right hand over left hand. Partly because, like you've had, the active pharmaceutical ingredient is not possible to produce it in Africa. Actually, the only places that it's been produced commonly is China and India, where they have already an underlying chemical industry, forget the pharmaceutical industry. So for us, we don't have a chemical industry. And so our pharmaceutical industry imports all of these APIs. For biologicals, you can be able to do everything from scratch. The APIs of biological content is the biological makeup, so we can be able to have everything A to Z of that value chain happening locally. Second thing is we also have the biologicals, then when you look at them, they're distinctive in terms of the advantages they have. And I've listed them there. Highly effective, very specific, so you don't have issues to do of antimicrobial resistance and stuff like that. Side effects are much less, not carcinogenic, again can I say safe, and easier to produce because we're able to do it's about culturing cells, it's about doing some fancy work with CRISPR or something else, and being able to work with DNA as a tool. And lastly, it's also a competitive edge. If you look at the current pharmaceutical industry, by and large, it's mostly biologicals that are coming to market. They are taking over and displacing the small compound drugs. Africa, I think, has 10% more genetic variation than the current reference that the industry is working on. So being able to work in Africa is amazing because not only are you able to solve the problem here, but also able to do good for the world. For once you can start talking about reverse innovation, even within the pharmaceutical space. So biologicals allow us to be able to leap from where we're in the story in terms of can we set up a chemical industry, can we now have an innovative pharmaceutical industry, all the way to where can we not only solve our problems but solve for the rest of the world. And I think that is a big part for us. In terms of disadvantages, like I said, yes, the world is going towards biologicals, but we are not in that reference. So we're already in an era of precision medicine or precision public health. And the question we need to ask is, can Africa actually even afford to get men? Typically I used to talk about what's our drug security. Nowadays I talk what's our drugs innovation security, because we are being left behind an entire continent of and the diaspora. And then the other side of it is also that, like I say, this genetic diversity will actually necessitate us to start thinking about precision medicine like yesterday. So it's both an advantage and disadvantage, but to me, either way I look at it, I believe that we need to start thinking about biologicals, not waste too much time in terms of the small compound. We have some generic industry that's going to do some work. We need to support that, of course, but understand how do we solve the challenges. And why do I keep talking about this? Go back to leishmaniasis, the Kalaza. What's the best approach for Kalaza? Can we come up with an mRNA vaccine that can just eliminate that disease? Why? Because when we're talking about importing that SSP plus PM, we're not even manufacturing it. The other place that is also an issue tends to be India. They are piecing it out. Then we'll be dependent on manufacturers that are not even party to the issues that we're talking about. So we do need to really move much faster. Moving to the next, and just before we go, no, my color scheme backfired on me. I'm going to read out that part for you. But I wanted to point out why I believe we can also do biological that last feature, that it's not like we don't have a place to believe God. Is there anybody who's not seen a city that's near them in the red spot in this room? That's raise your hand. And that's simply because, Zambia, Lusaka is there. But actually you can't get it. So the key thing here I want to point out is that we've actually invested in terms of life sciences R&D in this continent for decades. We start at engineering, and given that is true. But for life sciences, we know we have a really strong starting point that we should be able to leverage. And this data from 2010, I know it has continued to grow. Let's go on to the next slide. What was I trying to say with this slide? I think I can't read my own handwriting, as they say about doctors. So allow me to read for you from my smaller screen. The key I wanted to highlight is that if you're talking about addressing Africa's health challenges, we can't walk away from the issue of poverty. This is what we call a vicious cycle. And we're doing that again. If we deal with malaria and we don't deal with poverty, then that lack of incentive for the R&D, we talked about how capital intensive the pharmaceutical industry is, will continue to cripple us. So how can we succeed? We need to understand how do we take our challenges and turn them into an economic opportunity. And then that way, when we talk about partnerships, we say how do we build win-wins with our partners. The second thing is we cannot build a knowledge, and the only way to do it is basically to build a knowledge-driven economy. And that chart there is just the best way I can present it. How do we move from R&D to industry? How do we broker that transfer? There's a need for infrastructural investment, and there's also some need of piggybacking on our startup ecosystem, our startup economy in Africa. And sometimes I say this because I work a lot in the space, but we forget that we have a startup economy. It's now possible to create a startup, raise capital, and move ideas, spin them up from academia, and that becomes a new career track to address the brain drain that we've been talking about. So that we're not just training PhDs and then they leave us. But the second thing is also to point out that as we do so, we also need to not just adopt a quadruple helix approach. We also need to move from our nationalistic tendencies and start at least embracing regional economic blocks. Why? As I said, we have 54 countries. Our domestic markets don't amount to much, but together, there's something worth solving. We now have the African Medicines Agency that has been set up here in Kigali. A round of applause for Kigali. Hello. Our voice. But again, I'm moving very fast and leading the continent in terms of saying how do we come together and how do we solve some of the basic challenges of regulatory issues and fragmentary markets. That starts to make it much more possible to invest not just in startups but also in leveraging the infrastructure we have in academia, in industry, and within the financial sector. I'll stop there and asante sana.
Thank you so much. Dr. Francis is used to be harassing you a little bit. And thank you so much. I think you started from a very emotional point of view. And I think you preempted the conversations that will be happening tomorrow and on around precision medicine and why that is important, the issues of differential diagnosis. But one thing that I really loved, a statement that you mentioned, that without the right tools, then patients will die anyway. They will die either because of the wrong treatment and tools we are using or because of the disease. I think that's a message that we should always think about. That irrespective of what tools we have, if they're not the right tools for the right disease, used by the right people in the right manner, then we are just contributing towards the death of the patient in a different way. We are not helping that patient. You talked about the policy work that you're starting to engage. And I think the importance of us sitting here, we should also understand the nexus between the political and technical. A lot of the things that initially, politics was on that corner and health was on this side. But I think it is important that we recognize that health is a political agenda. I don't think there is any country, whether in global south or global north, where people campaign and you don't hear people talk about health as one of their biggest agenda. And it has been like that for some of the countries, like in the US for over 100 years, some of us for over 50, 60 years. Every other year during electioneering period, health is on top of the agenda, whether it is UNC, whether it is NHIF for us or any other thing. So we need to look at how then do we close the nexus between political and technical, so that we know at what point politics go and then leave the technical part to go, and people in this room should be able to get that. Your recommendations are quite precise. Thank you so much. I would really love, and this is through the permission of the overall MC, to allow me give room just for 3 interventions from the floor. I will ask for someone to help me with the mic. Just if there are any reactions from the floor, from the 3 presenters. But before that, let's also appreciate Dr. Karanja. 1, 2, 3. Thank you so much. Any hands? Going out once, I see one hand there. The second one, any? Okay, I think we're going just to have one. Oh, I'm seeing second there. Michelle, was your hand? Yes, 3. Thank you.
Thank you and good afternoon. I really appreciate and thank all the presenters. I'm Desari Inspire from USA, Rwanda. I'm a pharmacist, so I'll be talking about, it's a very interesting topic. I work as a senior supply chain advisor here. So from the overall goal of what we want to achieve in terms of economics and health. And I like the agenda of transformation and from the father that's opening remark and all the remarks that has been given. We want to make it practical, right? So all the presenters told us these are existing problems, right? The problems we know. Manufacturing medicine in Africa, there are a lot of issues, and majority not technical per se. It is more of political because there is no. I remember saying market-driven economy or market will not lead us, but in reality, market also lead. But it's not the only solution. So when I see manufacturing, there are many barriers, right? One was we have actual factories that combine different pieces to give us a finished product. But for us to manufacture that last product, there are many things to be combined, right? And there is no, when we say, if there is no end-to-end production capacity, ultimately there is no value added. It's just like another consumer. So where is the linking? We say we want to make it practical. So how can you make it practical? That's one question. The second is about, I think, I like the way Mr. Moderator said, oh yeah, how are we handling the one we have? instead of complaining for those who all left Africa. There are people rain or this. I see it as politics because I came from Ethiopia. Thousands of so in a continent where we have health professionals who are not hired, complaining for those who get jobs, that's the right thing. Or do we have another way of saying or addressing it? I've seen from multiple saying, yes, we lose this, we lose that. How can we best use those who left the continent instead of, seeing it in a different, I want you to see and give us what is possible. And from the last presenter, I think, this is the last program we see, those neglected tropical diseases, those orphan drugs, as we call it, some of them are not available, and they are manufactured in countries that they don't need, right? So how can we even make that a priority? Those diseases could have been eradicated or eliminated, but still here, and even we don't have the tools. And we'll still expect, and we're still complaining. Where is the truth and the reality? So how can we make it practical? Thank you.
Thank you. Those are really tough 3 questions. I believe each one of you is going to handle one. So I'll ask you to introduce yourself, where you come from, the organization, and then you ask your question. If you want to direct it to any of the speakers, please do. Thank you.
Okay. Thank you so much for this chance.
The presenters. So my name is Monica Buho. I work with the African Union, the Africa CDC. And my question is about the human capital and the brain drain. Because as a youth first, most of us want to go and look for greener pastures. And it says that I'm a Kenyan but I live in Addis. But that's just one situation. But again, the main thing is that even if we have brain drain, how can we tell the people who are going out of the continent? How can we engage with them so that the continent is not losing? And even though we keep these people in the political surrounding and even the environment in the continent may not be very conducive, even though we be honest. So how can we tackle that, and how can we also look at the diaspora? Thank you.
Thank you so much. Chef?
Thank you very much for the organizers, speakers, and each one who is involved in this initiative. My question, let me even start by also thanking everyone for giving us a comprehensive picture of key issues in progression of local pharmaceutical production in Africa toward improving essential availability in Africa. So Africa represents 95% of global demand for vaccines, but produce only 1% of the world vaccine. Within Africa, 99%, as it was mentioned, of vaccine doses are imported, with heavy costs attached to it, according to a speaker, Sister Eugenia. So African community members often have some myths, such as trusting products coming from outside to be a better quality than others and vice versa. So my question to the panel is, as we seek to increase local production, what are we doing to build trust among our community members regarding these production innovations? Thank you.
Thank you so much. The issue of trust. And then I give you the last before I can take it back to our speakers.
I'm James Handler. I have 2 issues on today. The first one, Dr. Eugenia, she talked about collaboration. Very good idea in production so that we can reduce the cost of medicine. But if what we are intending is to make sure that
medicine is produced in a cheaper way and more effective way, I think the politics of collaboration comes into play. What do I mean? There are people who like to collaborate who are very much focused on they are oriented on market. So they will not like to collaborate with you if they know their market share will go down. So how do we navigate about this? And the question to that, the issue of contract also. The other is on human resource. We talk so much about human resource, and Dr. Kabore explained very well. But I'm wondering whether there's been any study to see, because I'm not the neglected tropical diseases. What is the human capital like? What's the map like for Africa? Because most of these diseases, I don't think they need surgery. Most of them, and they straight need medicine. So what is in the map of the African human capital, those who study? How many of us study this particular neglected tropical diseases? And then the related question is, we talk about brain disease. Then when they go out, if our brothers and sisters go out, I always hear is especially for us, they have to go into another process to be accredited in those countries. In another sense, we hear they are not just accepted and embraced. So what do they actually do there? If they did study of neglected tropical diseases and they go to this, let's say to the northern hemisphere where this disease do not exist, what do they actually do there?
Thank you so much. I would like to start with Sister to provide some response, if there are any, from what that came to you, before I come to Ron.
Thank you very much. These are very, very important questions. I will start with the first one. I'm not sure if I heard it. I think she was asking about how practical the recommendations are. That was what you were asking. So I'll just take one of the recommendations, innovative finance. This is an IHT conference. And when you look at the children of IHT, the first one is the Ubuntu Foundation. And through that foundation, they would bring together, or they would encourage potential producers to produce not at a loss. And so they will take out all the lack of incentives that potential producers have from manufacturing in Africa. I just want to see the face of the from manufacturing in Africa. For example, if an investor is hesitant to produce because it's not aware, it's not really sure if it can sell it at a price at which it can benefit, Haiti will be there to absorb any loss, to ensure that it is still profitable to produce such products. Yeah, so in that case, I mean, if you're talking about a practical aspect, these are just an example that I can give. Also, innovative financing can also take the form of joint ventureship, so that the investors will come in and collaborate closely with the local manufacturers and produce and share the profits. You know, very often when we are talking about, well, so this will also respond to the question on collaboration. When Africans sign partnership contracts, in the end, we do not benefit as much as we should. For example, if you take oil, let me move away from the pharmacy world. If you take oil production, they'll produce the oil, send it abroad, sell it abroad, export it. But then the funds are supposed to come back to the country to support the local currency. That doesn't happen. And so we end up having weak currency, high inflation, wiping off any gain that could come. This same thing could happen in the case of getting into collaboration if we don't take the interests of the local economy into account. So we want contracts that will actually create jobs, you know, so that Africans will be better off as a result of the local production of medicines. And I'm not sure if that responds to your question. Yeah. And I think the next question is about trusting locally manufactured products. Yes, when I was speaking, I said that about 42% of counterfeit drugs in the world are produced in Africa or are associated with Africa.
Because brain drain is people going in other parts of the country to look for green places, better places. And this is it's a difficult situation because this is a micro problem. As an individual, you decide to go to a better place where your knowledge is better rewarded. But when allocated at the macro level, it becomes a problem for the country. So how do we solve a macro problem that has micro foundations? This is the issue. The second issue that was raised by the first person was, the question is brain silencing. Brain silencing is often due to political pressure. We have people who are very well trained, they come back to their country, but because they don't have the right political card or whatever, then nobody cares about them. This is brain silencing. Then brain atrophy is the fact that some people can come back home with very good will, but they are not in the right environment to thrive. So at the end of the day, they are not using their brains. So this is brain atrophy. And what this means is that if we think in the context of the quadruple helix, then we can solve this problem. Because then government works with industry, with academia, those who are very well trained and so on, to solve this. The second question about trust. Trust, of course, can be developed only over time. But trust is not something that you can decide like that. It has to be based on data, what we call like data-driven argumentation, data-driven. If you create a product that is effective, whether many people like you are not there to buy it. So how do we make sure that, as someone mentioned, we come up with African products that has good quality? This is the issue. And of course, it needs also over time to market it so that people can understand that something or things that are very good and excellent can come from Africa. And this is a challenge. We often go for very easy solutions, cheap solutions, and as we often say, cheap can end up being very expensive. The last point is about human capital. We talked about brain trade, but as a matter of fact, when people go abroad, they end up being retrained. As a matter of fact, most of these medical doctors from Nigeria, Ghana, and so on, who go Kenya, who go to the US, most of the time they spend their time working first as nurses, while they are getting retrained to be medical doctors. Or you can die working just as a nurse. But the problem is, and I have done some studies on the economic gain of these countries, or what we call the receiving countries. When you have a medical doctor, actually in the receiving country, he ends up working as a medical doctor, but he is paid as a nurse. And the difference in wage is a gain for the receiving country. So actually, even the person who migrates, he's better off because he's better off than when he was back home. But he is not as better off as people with the same level of training in the receiving country. That's the first thing. The second thing is why these people have to be retrained. If you look at most of our universities or whatever, you will see that someone who is doing chemistry, biology, and all those things, how are they being trained? They are getting information, they are not getting knowledge. And allow me to make a small difference here. Information, the best way to make the difference between information and knowledge is that information can be duplicated. Like if I take this, assume that this is a document that tells you how to fly a plane, a copybook. I can copy it, or I send you the soft copy to all of us, and all of us will get it in 1 second. How do I manage to train all of you to be able to effectively fly a plane? If this was a plane, and I tell you, please fasten your belt and relax, I'm Professor Francois Kabobe, I have the notice about how to fly a plane. Who is going to stay in this plane? But I have the information about how to fly a plane, but I don't have the knowledge. Most of our people at university, they get information, they don't get knowledge. And that's why, of course, knowledge is an input for knowledge. Sorry, information is an input for knowledge, but when you are stuck at the information level, you cannot make things happen. We have many people who are trained physicists, but they never experience the thing. We are setting up a university in Burkina Faso called Samuel University of Science. I already sent a few professors to be trained overseas. Most of those people who go overseas, is their first time to really understand what they learn and do experiences where they got A's back home, but they never understood what it meant really. So in matter of human capital, the challenge for us is to train effectively in our universities, in our schools, so that people get knowledge and not information. If we do so, I think we can make things change. Thank you very much.
Thank you so much. I hate it. There's a very important thing that I think you need to pick there. With the concept around training and capacity building, which is one of the 6, is thinking about how do we transform that information into knowledge. I know it's about time, right? I know. Can you allow him to respond to the last question? Then as I give you the mic to take us to the next, wherever you can speak kindly. Thank you. And we are so bad doing badly about time.
I'm not sure that there's any question remaining for me. But I think to me, I want to just put that question, how do we make this thing practical again? And I kind of hear where you're coming from, but I also disagree to some extent. We do amazing research on this continent. If you look at what that 1% of scientific output that comes from this continent, I'd say roughly between 60 to 80% of that would probably be life sciences, agriculture, health, environmental. Now, the question is, how do you translate it to a proper solution? It's one thing to do science in the labs. It's another thing to translate it into a product. And what happens is within that value chain, that continuum, is we have a missing link called design and engineering. And as I said earlier, engineering is just our weakest link on this continent. I don't know, I think almost all my engineering, the people that I grew up with that are engineers, most of them are in management. They make excellent CEOs. They think they're passion, they're good at problem solving, so they're hands-on kind of, the way they are trained to think, other people benefit from it, the bankers and everybody else, because nobody has invested in the infrastructure. And I think we've got the answer today from the Washington consensus why some of this was not just plans, there's some decision making that led us down a certain path. So the question is, how do we fill that gap? So that then we can be able to link academia to industry. Because what has been happening is, we say we want to manufacture drugs. Moderna comes in, BioNTech comes in, and they set up an EPZ platform. We will produce, they'll bring the technology transfer, we'll provide the cheap labor and the tax breaks. And that's it. It's not linking to our knowledge base. Second thing is, how do we provide capital that is risk capital? Because when Sister Engineer talked about innovative financing, I'm so 100% there. Some of the things that we've tried to experiment in Kenya is even talking about how do we structure impact bonds, a social impact bond or a development impact bond that allows you to back-end the risk for government to put in money into a knowledge-intensive pathway for this vaccine production. That is stop with this EPZ model that works well for textile, and again, we're left nowhere. So it does not link up with any of our local value chains. But it's something that you have to raise the conversation a lot, because we're struggling. And I think the last part is to say, the key thing I see coming out of it all is how much disciplinary the kind of thinking we need to have. We need to think for the engineers that are not here with us. We need to think for the treasury folks that are not here with us. We need to think for the investor who is looking at it purely from a commercial perspective that's not here with us, and then still understand that scientist that is trying to solve the issue of Kalanza. So it's not easy. And I go back to what you said, the quadruple helix. We really need this like yesterday. But what I can say is that within the fintech space, for example, last year I think we were the only region in the world where the VC investment to Africa did not go down. We actually improved slightly more than the previous year. And so you're talking about hitting $5 billion. It's not a lot, it's probably less than 0.1% of the global VC capital. But the question is, we have momentum. And that has been like almost year on year from the previous year of 100%. So it's growing. And this is building for us the financial capacity to look at technology, provide risk capital, and start seeing a knowledge economy happening. So all I ask is, what's making it work in fintech? What do we need to do to make life sciences, biotech competitive as a sector? If we are to frame it that way, we realize the building blocks actually already exist. It's a matter of us connecting them and making sure that we start talking to one another. I'll stop there.
Thank you so much.
Good afternoon, ladies and gentlemen. First of all, I just want to share a Haiti's thought on the issue of brain drain. Father Charles is here, so I'm sharing the many discussion, not for me as the chief execution officer, because normally say CEO means chief executive, no, chief execution. So mine is to take what you guys are, see how it can work. So when we discussed with Father Charles one day when we were coming from Ghana, when we had a conference in Ghana, coming back on a flight, and we were discussing about what is this brain drain in Africa. And my eyes thought of Dr. Eden. Dr. Eden, you can raise up your hand so that people can see you. He's running an innovation in Ghana, in Accra. We understood brain drain very differently from that point, because Dr. Eden was working for Johnson & Johnson. And he told us there are so many other doctors working for these big pharma companies in the US. But it is not that they are greedy to go to the US, all those countries, because they're looking for greener pastures. We found out But what you said was that the skills cannot match our needs. You know, those doctors who we have in Kenya, you're a biomedical scientist, and there's no biomedical research facility to apply your skills. So you go where it's applied, because it will be only fair to put your skills where they're applied. So with Haiti coming on board, our urge, Father is now saying brain diversion. That is his what? Yes. So without setting up something like Haiti, which will promote the biomedical research facilities, where biomedical research experts can do research on, we will be suffering brain diversion while we think it's brain drain. And that is what Haiti believes in. That's why we would like to set up these 7 children of Haiti, will ensure that Africans who cannot match their skills with opportunities in the continent will find where their skills match. And Dr. Eden told me, Fred, I can call those people by name and call them on phone and give you their numbers, and I'll call them when their skills can be matched with opportunities in Africa. And please help me do that. And then my last one, which is overarching here, is, if asked the question, do you know how much it costs Qatar to host World Cup? Do you know how much was spent in Qatar World Cup? Do you know? Between 300 to 400 billion US dollars was spent to prepare and to run Qatar. After that, what have we seen? No, you go to Qatar, you see a stadium, you see that. And when someone tells me we cannot raise $6 billion US dollars to treat people who are sick, then I wonder, maybe I'm the one who's sick. Because I'm telling Fred, why are you being ambitious that you can raise $6 billion to finance healthcare, which is an ongoing industry, but for a few days over this November, December, between $300 to $400 billion was to kick the ball, a piece of leather. I'm a football fan, so I'm sympathizing. I also like kicking leather, isn't it? But can you imagine that's where we spent 300 to 400 billion US dollars? But what is ROI, Father? You are an economist, you're a professor of economics. But if we can just get 6 billion to ensure that Africa can be secure in terms of health. So anybody telling you that there is no money, no, there is money. And as a philosopher, we believe that the eyes of the soul is not blind. But it could be looking in the wrong direction. We are looking at football to be more important than people's health and life. I'm not telling you not to spend money on football, but let us believe also it's possible to raise the $6 billion if we believe that we want to do it. And because we believe, I am very hopeful it will happen, and that will be the chief execution officer, not executive. We can put our hands in the dirt making. I'm seeing Professor of Pharmacy is raising up his hand. I will not stop but give him the microphone.
I just wanted to close this, but for the sake of closing the session, we had 3 presenters. And I want us to do what we call the 3 factorial. Oh, Prof is here, and
Thank you very much. Thank you very much. Thank you very much, Fred. So I'll introduce myself very briefly. My role is to give you words of wisdom. That's why you're my name. My name is Kokwaro. I'm a professor at Strathmore. I've been a professor for the last 30 years. Just call me sir. That will do. So I want to summarize before the thing. Lunch will come. Let us summarize with your permission, sir. Yeah? Yes, sir. With your permission. Thank you very much, the presenters. So I'll be very, very brief. Very, very brief, and based on what you have said, and what the presenter has said, and the journey we want to do so that we can move forward. That's really my role at my age. 1. So someone has said that Africa produces what it doesn't consume and consumes what it doesn't produce. That's exactly what we are trying to do in terms of health. It's not something we can continue in terms of medicines and the rest of it. So those of you who are not health system experts, I'll make it very, very easy. There are only two challenges with health in Africa. Two. The rest of the people can say that let's say I don't agree with them. So one, insufficient funding. And that's of course because health is not the only thing we are doing. Insufficient funding will be that. But having said that, that's just one side of the coin. Inefficient use of available resources is a major problem. I really won't go about brain drain and those kinds of things. It's one of the inefficient use of available resources. So what if an African is working in Australia? They can still do that. We can still make use of that. I think we should shift from this kind of thing. Those are the inefficient use of available human resource. It's as simple as that. Whether you agree or not, I've said it. Thirdly, we have the Africa CDC here. And we have the African Medicine Agency here. What we should now do, how do we use these vehicles to make our process efficient? Period. You get it? So that we use that, we can use this. They were not there when you were born. They were not there earlier in the 90s. When I was part of the group of the few Africans who helped create medicines for malaria venture in Geneva, the one that produced it, we did that, a few African scientists. And it seems to be working. So I think the inefficient use of available resources, this could be partners from Germany, this could be people willing to help us. We just need to create that environment and remove these barriers and we form a few viable regional or sub-regional clusters that we can. And I agree with you. Finally, it's always safe to say I agree with the boss. I agree with you that it can be the vehicle towards that one. I rest my case.
Thank you so much. Thank you so much. I wanted to, and Prof, it's always a pleasure listening to you and the challenges you pass to us. 3 factorial for our 3 presenters. We understand what 3 factorial means? It's 3, 2, 1, okay? Let's go. And 1 factorial for the moderator. Let's go. Thank you so much. My name is John Polomono. I work for PATH, and it was a pleasure moderating. Thank you.
So thank you very much. I guess you can tell that that wisdom was worth tapping, and that's why I said there was no reason to think we're in a hurry. And he has assured us that lunch will come. So in those very few words, you saw that you received lunch. It's called what? Coupons, isn't it? I'm sure that you know where we are going to have lunch, isn't it? Just outside here, the participants will just get their lunch within this place. There's a place as you enter on this side of the left, and very poor with direction. There's a place where you can be able to have your lunch. I'm sure you'll be guided from. Okay. Lada Restaurant in Radisson Blue Hotel, which means you cross over and there's free sitting. So don't think there's a high seat, low seat. We are all a Haiti and we enjoy the very spirit of Ubuntu, isn't it? To share with each other, brother and sister. And of course, the lunch break is 1 hour. So we come back by 2 o'clock. We are 1 hour behind schedule. So the people who will be running the next session, they will unlearn from the one which has been very rich, but time now will be holding us. We'll give you time and finish on time. In case anybody has anything that they want to know, any concern, it's very easy to reach me, as you can see. Just call me. But for the board members of Haiti, the board of trustees, we are having some kind of a lunch meeting, isn't it? We are having a lunch meeting, so you stay behind. I'll direct you where the room will be, where there will be both lunch and also meeting. You know, in this world, once you have high responsibilities, you don't even eat. You are eating as you meet. I'm sure you're very familiar with that, everybody who is here. So, for now, I think that this don't time and ask the prayer. So, Father, can you bless the meal?
It's nice. Please. In the name of the Father, the Son, and the Holy Spirit. Lord, we thank you very much for your wondrous deeds. We thank you for all the ideas we shared here. As we are about to share a meal, bless us and give us strength so that we can continue to work for your greatest glory. In the name of the Father, the Son, and the Holy Spirit.
Bon appetit. As you come back from lunch, at the desk you'll get your name tags. So when you come back, at least pick your name tags. The name tags came from another country, and that country has got a very serious standard deviation in terms of time. So you'll pick them as you come from lunch.
for asking.